Good morning. On behalf of the Center for Behavioral Health and Justice, the Michigan Health Endowment Fund, and the Michigan Opioid Partnership, we welcome you to the second Opioid Treatment Ecosystem Community of Practice Virtual Summit. I am Liz Tillander, the Deputy Director at the Center for Behavioral Health and Justice. The CBHJ, as we're known, is a community-based research center that provides local communities with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison. We do this through the implementation of best and innovative practices at every intercept of the criminal justice continuum. We are so glad to have people from all over the state joining us this morning. Attendees at today's summit include first responders, jail administrators and frontline staff, medical professionals, behavioral health providers, State of Michigan and funding partners, and those directly impacted by the criminal legal system and this overdose crisis. Today, you'll hear from national leaders who are working to improve treatment ecosystems for opioid and other substance use disorders, especially where they intersect with the criminal legal system. In addition, you'll learn more about one of the CBHJ's current initiatives that connects first responders with treatment providers in their communities. While much of today's content will be about specific programs and initiatives, all of it is focused on the larger goal to reduce overdose deaths in our communities. Before we begin, a few housekeeping items. In an effort to facilitate a high-quality event free of distractions, we have disabled the microphone feature for attendees to eliminate background noise. Though you'll be unable to verbally engage with our speakers today, we encourage you to use the Q&A feature at any time during the event to ask any questions you may have. All presenters will be able to answer your questions towards the end of the event. Finally, we'd like to acknowledge the generous support of the Michigan Health Endowment Fund. The Health Fund makes it possible to offer this event as part of the Opioid Treatment Ecosystem Community of Practice. Now I have the great pleasure of welcoming Becky Cienki, Director of Behavioral Health for the Michigan Health Endowment Fund, to offer opening remarks for today's summit. Becky is responsible for designing and implementing the fund's behavioral health grant programs, overseeing grant activities, and developing partnerships aligned with the Health Fund's mission. Becky has spent her career supporting safety net organizations to improve access to quality care and is passionate about improving integrated services and supports. Thank you for all you do, Becky, and welcome.
Thank you, Liz, and thanks so much to all of you for your leadership on this project and the opportunity to be with you today. As some of you may already know, the Health Fund is a philanthropic organization in Michigan focused on improving the lives of children and seniors. We have 8 main focus areas at the Health Fund, and one of those is behavioral health, where we aim to increase access to mental health and substance use disorder services in Michigan. Last year, we released a study in Michigan analyzing access to behavioral health across the state for all insurance types, geographies, populations, diagnoses. And we found that for those individuals with mental illness, only 2/3 received any treatment last year. Even more alarming, the majority, or 80% of individuals struggling with substance use disorder didn't receive treatment. As you probably already know, there are many reasons people aren't receiving treatment, including provider shortages, cost of care, reluctance to seek care. But we also know that navigating the behavioral health treatment system is incredibly challenging. Many of us can think of a time when we've tried to support a family member, a friend, or a neighbor in figuring out how to enter treatment and finding it to be a very complex maze, often leading to multiple dead ends. As the Health Fund thinks about supporting entry to substance use treatment, including treatment for opioid use disorder, we know it's critical to reduce the number of dead ends that people encounter and providing more entry points to care. This sort of effort really requires cross-sector partnership, and for many, this requires moving beyond an already stretched workload. The criminal justice system is a critical partner in this work, and we know that serving as this entry point is not easy. I'm sure it's been an incredible lift for so many of you. I really just want to take a moment to tell you how appreciative we are of the work of Wayne State and each of you and the work that you're doing to take on this truly important challenge of supporting individuals as they enter and begin their recovery. Thank you for taking on the work and for the lives you're impacting. I look forward to learning more about the work you've done to date and the work ahead.
Thank you so much, Becky, and thank you for joining us today. Now I have the honor of introducing Brandon George. Brandon is a national expert in substance use treatment and recovery and is currently the Vice President of Mental Health America of Indiana and the Director of the Indiana Addiction Issues Coalition. He oversees the Indiana Recovery Network, which delivers peer support to all 92 Indiana counties. He has trained judges and law enforcement around the country and has even spoken at the White House on the need to develop a strong workforce of addiction professionals. His TEDx talk, Junkie Human Revolution, helps shine a light on the stigma of addiction. If you have not yet watched it, please do. It's excellent and brought me to tears yesterday, so make sure you have tissue when you do that. We are honored to have Brandon here today to learn about the groundbreaking work he is doing to expand treatment ecosystems in Indiana and across the US. We anticipate that his story will inspire all of us to continue working together to strengthen our local treatment ecosystems and to reduce overdose deaths right here in our own communities. Welcome, Brandon.
Thank you, Liz, so much for that really, really kind introduction. I'm really grateful to be here today. I'm sorry we can't be together in person as we had originally planned on. That being said, there's a good chance that everybody might get to meet my dogs today because they are sitting right next to me. So if you hear Dixie, Uno, or Olive, we'll consider that a side benefit of doing all of this virtually. Again, I'm grateful to be here today. The folks that you guys have at Wayne State, I know that it's hard to, you don't always notice it when you're in the middle of it, but Matt Costello, Brad Ray, some of these folks are known well outside of Michigan for their work on this topic. And so I am equally as grateful to be around Wayne State and get to talk just a little bit about some of the work that we've had going on over the last couple of years, both in Indiana and across the country. A lot of what we're going to talk about today is really this intersection in between public safety and public health. It's difficult, it's nuanced, it's hard. There is no quick, easy fix. As Liz talked about earlier, the general treatment ecosystem for addictions is really broken. It's been siloed off from regular healthcare for decades, and so we don't take the same path to get addiction treatment or substance use disorder treatment as we do other healthcare issues. And so the way I want to start out today, we're going to talk about some of the things I'm involved in professionally. I'm an addictions counselor by training. That's what my education's in. But how I want to start off today is talking to you as a person with severe substance use disorder, severe opioid use disorder, and somebody that has been heavily involved in the justice system from a very young age. And to really try to give some narrative and some context to what the system looks like to somebody who is going through it as a participant, so to speak. And so I'm not going to give you every gory detail, but I started using at a fairly young age. I think probably around the age of about 13 or 14 is when I started drinking on a semi-regular basis. A lot of the similar progression that you hear about people, starting off with marijuana and alcohol, and along that point, we talk a lot about gateway drugs, and a lot of people start off with that trajectory that I just said, right, of marijuana, alcohol, and then on to harder drugs. But we know now there's a lot of data about the gateway theory and how it's pretty inaccurate. What we have found out through the gateway theory is that trauma is the real gateway drug. Adverse childhood experiences are a huge indicator of somebody having substance use disorder at a later time in life. And so I was one of those people. I suffered abuse in the home. And as I tell a little bit about my story, you'll be able to identify some other traumatic events that I experienced that really played a massive role, I think, in my substance use disorder. You know, I wasn't able to identify that at the time, but, you know, hindsight being 2020 and being able to look back at my life, I can definitely see where I was using to, you know, escape that pain of the trauma and the adverse experiences that I had went through. And so I always have this slide up here just to get the brain thinking a little bit, you know, is addiction really a public health issue? And so we say it, we've got names on institutions that imply it is. It is, you know, the politically correct thing to say, correct? But even though we acknowledge that, it really historically has not been treated as such. And so even though we're saying it's a public health issue at this point, even though we're saying that we can't arrest our way out of this problem, the vast majority of people inside of jails and prisons have substance use disorder, have mental health issues. And so I'm glad that we're trying to turn the big ship, but I think it's important to acknowledge that this is, you know, so intertwined with the justice system that it's nearly impossible to really get it out. And so, you know, as I started to use on a more regular basis, I started to pay consequences pretty early. And so that's the easiest definition really of addiction to me. There's a lot of scales, there's diagnoses to be made by some people probably attending that can do so, but the easiest way just objectively to look at a situation is somebody that continues to use despite negative consequence. Right? It's the hand on the stove situation. Normally somebody puts their hand on the stove, they get burnt, they will never, ever participate in that behavior again. And so a normal person gets a DUI after watching a football game at the local bar. They spend the night in jail. It's a terrible, terrible, terrible experience. Their boss tells them, you know, if this happens again, I'm gonna, you know, we're gonna fire you. And a normal person without alcohol use disorder or substance use disorder would probably modify behavior there. I'm not saying they're going to stop drinking necessarily, but they'll probably stop drinking and driving, right? They'll maybe call an Uber moving forward, or they'll watch the game from home instead of going out to the bar and watching it. That is a typical response to, you know, when somebody gets a punitive action or experiences a negative consequence from the results of a behavior. And the difference with people with substance use disorder, we talk about, you know, the reward system being hijacked and the brain kind of being hijacked. This is part of it. You know, your brain will convince you to keep doing something that is detrimental to you. And that's not normal. We're built to do reinforced behaviors that help us stay alive, like eating food, for instance. And so when we keep doing something that we know is causing us pain, that's a good identifier that there might be a substance use disorder that's prevalent. And so, again, I started experiencing consequences really quick. I was kicked out of my first school at 15 for having a party in the radio station. I don't know why I didn't think that smoking a bunch of marijuana inside of a school and having alcohol wasn't going to get us caught. I tell you about the story because I want to identify that, you know, we can't raise hands because we're not in the room, or maybe we can. I don't know if you guys, participant-wise, can raise your hand. How many of you guys think that I received a assessment for alcohol and drug use when that happened? How many people think that they brought me in to see if I had a problem, possibly, if I had a chronic condition? I'm guessing nobody thinks that happened, and it definitely did not happen. They viewed me as a troublemaker. I actually had to sign a piece of paper. I got kicked out. I had to sign a piece of paper that said I wouldn't go back on the property for another 5 years. And so that's how substance use disorder was treated. And still to this day, a kid I was just helping, 16 years old, marijuana situation at school, and he's kicked out of school. Never been in trouble before. And instead of getting this kid help, we pushed him off to the side. And so you would think a normal person would stop using at that point, right? Or modify behavior. Not so much. And so I ended up going to another school, getting kicked out of another school. My drug use started to progress. Instead of just using mushrooms and alcohol, I was drinking during the week as well at this point. And started to use a little bit heavier drugs, cocaine, acid, some others. And with cocaine comes a whole bunch of other problems. Instead of trying to come up with $5 or $10 over the weekend to use drugs, I was trying to come up with 100, which led to me starting to sell drugs. And so again, we've got these ideas in our head about what things are. We know the majority of people that are quote unquote dealing drugs are doing so to support their own habit. Just like we do in the office, right? I buy, you fly. I'll pay for it if you go pick it up. Well, same situation happens a bunch here. People run around and pick up drugs for other people so that they can get a free lunch out of the meal, out of the deal, so to speak. And I did a lot of that. I did a lot of going to pick up the lunch so that I could get everybody else's lunch so that I could get my own lunch. And so we do this in so many other areas, but somehow when people do it with drugs, we look at it so much differently, as people are bad people. And so I would cause us to, re-examine this just a little bit. I'm not saying that Pablo Escobar doesn't need to be in jail, but we've got a lot of people doing a lot of time in the jails and prisons because they have substance use disorder. And so more negative consequences really started piling on. I got kicked out of that second school within a year. I had 2 of my best friends die. Both of them actually were murdered. I'll never forget getting the call that day. My grandmother actually, before everybody had cell phones, came over to where I was at to tell me the news that Evan had been shot and murdered, as well as a friend of mine, Terry. And the bigger piece to that, well, there's multiple pieces to it, and nothing is bigger than them passing away and dying. But other factors were that the 2 people that murdered them were also people in our social network. And so in this one day, you had countless lives that would be changed forever. One of them ended up getting 65 years. The other got 55 years. And a whole group of families and people would be changed forever. I didn't think it could get worse that day, but it did for me personally. About 2 weeks after that, I found out that they had been murdered over drugs that I had sold. I had sold one of the guys some cocaine, a 1/4 ounce. Just for you guys that don't know, that's worth about $250. So these people, all these lives were changed over $250. I'd given the drugs to one party. My friends had stole it, and in retribution, they killed them. And so I carried that around for a long time, that I was the cause of their deaths. As mentioned, these adverse traumatic experiences definitely expedited my addiction. It definitely made me use it at a higher rate. I moved out of the house around that time, quit going to the alternative school I was at, and moved in with a girl and had a baby on the way within a year. I was 18 when I had Riley. Was working in the restaurant business and would continue to do so for the next several years. I ended up getting multiple DUIs. During that time, I got put on house arrest. Again, a lot of consequences for my alcohol and drug use. I would be able to sober up for a period of time. And then as soon as, the bracelet was off from my house arrest, I'd be right back to it. And so my 20s would really end up being a revolving door of me getting arrested and trying to control my drinking. And then the episodes of going into treatments would start. The first time I went into treatment, I was able to stay sober like 9 months. And I actually had an idea in my head that if I were to use again, that all I needed to do was go to detox and everything would be okay. And that's just not the case. Substance use disorder is chronic. It gets worse over a period of time. And so I ended up going to, I think, 9 different inpatient facilities, a total of 6 different places for a total of 9 times. And every time I went back out to use, it got worse. The first time I stayed sober 9 months, the next time was 5 months, the next time was a couple months. And before you know it, I was so controlled by drugs that I would leave a treatment. 14 days into a 30-day treatment, I would leave. And I just could not resist the craving. My brain and the behavior was so singularly focused that the only thing I could think about was satisfying that craving to use. By this time, I was an IV heroin and meth user. My last couple of years were spent unemployed. I didn't work for the last 2 years. I only see my daughter a handful of times over that time frame. Ultimately, not working would lead me to couch surfing. I spent the last couple months of my using living in a laundry room in downtown Indianapolis. And, I thought I was probably going to die there. The future didn't look good. I didn't think the treatment worked. There was, I would go into these stints and leave, or once I left there, it was always an acute care approach. And, we talk about this being a public health issue, but we also talk about it being a chronic condition. And chronic, like cancer or hypertension or diabetes or congestive heart, if you had cancer, even if you beat cancer and you went into remission, you would still be in contact with that healthcare provider for like 5 or 10 years, probably the rest of your life. You'd have increased screenings. But our substance use disorder system, it's set up like an acute care model, like it's a broken bone. You get treatment for a matter of days or weeks. If you're really, really lucky, you might stay in a program for 6 months. There's no coordination of care. The system's fragmented. And that was my experience going in and out all these times. And so on December 18th of 2018, it all came to a crashing halt. I got arrested again, sat in jail for a period of time, and went into another treatment. And, I don't think that, there wasn't a feeling that this was any different than any of the other times, except for I took care of a couple really key things while I was in treatment. And something else I started realizing is that, what's really the goal here? My goal always was to complete treatment. And what I started realizing and what I started being taught was that treatment isn't the goal. Recovery is the goal. And, treatment is a vital, vital component, but it's one piece of many. And so there's 4 dimensions to recovery. Home, health, community, and purpose. And so the health piece is the treatment piece, right? So I went into a residential treatment facility. Usually it lasts 30 to 90 days. I got cognitive behavioral therapy there, which is evidence-based. I had peer supports, which is evidence-based. Was able to get some counseling for my trauma, which was something different I had never done in the past. I was able to get medications for my opioid use disorder. If we're not on board with medication at this point, we really need to it's on us to figure this out internally, because it's the gold standard of care for keeping people alive. Look, we want all our diabetics to exercise and work out, but we give them insulin to make sure they stay alive where it's warranted. And if somebody has severe opioid use disorder, they had better have a medication to make sure they stay alive. And this was part of that. And so there's the treatment aspect of it. The home aspect of it. I stayed at this residential place. It transitioned into recovery residence, and I stayed for 11 months. So I stayed in a structured environment. This is really important. People leaving the criminal justice system, making sure that they are going to recovery residences or other places. Substance use disorder is generational, and we know that a lot of times people are going back to really terrible environments, and sometimes it's their own family. It can be their parents, it could be grandparents, it could be aunts, uncles, sometimes children, depending on age. And so I stayed in a structured environment for my first year of recovery. Community is another piece of the puzzle. And so we used to think this was all of the follow through, right? We used to do treatment and then send them to AA afterwards. And that's the community piece, right? The social support. And let me, just in case, I'm sure everybody knows this on here, but just in case they're not, AA is not treatment. 12-step recovery is not treatment. These are social supports. They are vital. They are really, really important. They played a key role in my recovery. Still to this day, I participate in social supports, but they are just that. They are social supports. They are not treatment. And so, we'll talk about the judiciary later, but that used to be the go-to, right? Just making people go to AA meetings. And we know that the treatment piece needs to be much, much more robust. And then purpose is the last area, right? What do we do every day when we wake up? Education-wise, going to school, or employment-wise. Faced a lot of discrimination and stigma since I've been in recovery. I remember working at a restaurant for about 5 years, was a supervisor for several years. Alarm code to the building. I had the combination to the safe. I made the schedules. But they wouldn't let me be a manager because of the felonies on my record. So despite the fact I'd worked there for years and they had a body of evidence that I was trustworthy, again, clearly they trusted me because they gave me those responsibilities. But they continued to pay me $13 an hour as a supervisor instead of $45,000 a year, which is more like $22 an hour because of my criminal history. And so, education-wise, I went back to school, as mentioned, my trainings in addictions counseling, and was able to get a degree there, and ultimately transitioned. That restaurant, luckily, and this is important, we all need advocates, and it's important that we advocate for those we believe in that are in recovery. I had somebody from the corporate office there essentially went to bat for me and said, hey, at this point, if we're not going to put him into management, I'm going to have him look for another job because he can't do any more to prove to us that it's worthwhile. And it ended up working out well. I ended up being a manager of that store, then a general manager, and then I oversaw multiple of the restaurants. And so, I ended up overseeing a treatment facility that did work inside of corrections. That's how I got my tie into corrections. We had a therapeutic community for this has been years and years ago when this was like a novel idea. At that point, just doing even, Vivitrol alone inside of a corrections facility was a novel idea. Not the case anymore, but it was then. The program in Indiana got picked up by leadership. The Attorney General here came and saw it. We had members of Congress come look at it. And they modeled it. They ended up replicating it in, I think, 8 to 10 Indiana counties, and kind of became a standard for care inside of corrections here in Indiana. Since then, I've transitioned into my role as the director of Indiana Addictions Issues Coalition, and I want to talk about some of the projects that we're working on. I'm going to start off with some of the national ones. One of them, Legal Services Corporation. They provide legal aid to people in every single county or every district in the entire country. Some of the things they fight for are making sure that mothers are able to maintain custody of their children, even if they have substance use disorder. As mentioned, medication is the gold standard for care, but we've got a lot of states, a lot of Department of Child Services that will not let mothers have their children back if they're on medication for opioid use disorder. Think about that. You do what the doctor tells you to do, and as a result, they won't let you have your kid. And so something else they've been involved in, they help out and are involved in other related issues. There's been a lot in the courts around whether or not medication's allowed in jails. We know now there's been multiple rulings that indeed that jails have to let people take medications for opioid use disorder for 2 reasons. They said it violated the Americans with Disabilities Act, and they also said that it was against the 8th Amendment, cruel and unusual punishment, to make somebody go into withdrawal. And so you're starting to see that tide turn. Hopefully most of our jails are going to do it willingly, but they're going to be open to some legal ramifications if not. The National Judicial Opioid Task Force, this is one of the things that I'm most proud of. I got to work with our state Supreme Court Chief Justice Loretta Rush and several Chief Justices from around the country to come up with material to train judges, trial court judges across the entire country. So we created a document that lays out evidence-based practices. Judges can't be experts in everything, and they need bench cards and things to direct them on what the most appropriate treatment is for things. And this really dives deep into how to treat pregnant women, the efficacy of medications for opioid use disorder, the efficacy of peer supports, the need to have transition teams and really comprehensive interdisciplinary teams around people in their courtroom. And so the goal is this has been distributed to the different chief justices around the country, and then they can use that to help train their trial court judges within the state of Indiana. We presented this at the Washington, D.C. Press Corps last November with the Surgeon General and the director of the Office of National Drug Control and Policy, and is being used to train judges right now across the country. O'Neill Institute from Georgetown has had a series on medications for opioid use disorder in jails. I've put a link on here. I think that we're going to send this out to everybody as a summer series that talks about ways to implement jail-based MOUD for folks in rural settings and mid-sized settings, because that's what mainly America is made up of, and is providing a toolkit to be able to do so. Another group, the National Council on Behavioral Health, helped train hundreds of law enforcement from all over the country this January, right before we shut down for COVID in Rhode Island. Rhode Island has a tremendous model for implementing medications inside of jails. And so we were able to go out to Rhode Island. I think there were about 300 law enforcement and corrections folks that showed up here to learn about a variety of things that go into this, because it's not just about adding the medication to the formulary inside the jail. There's so much more to implementing medications inside of jails than doing that. I put this in just as another resource. We did a blog. Professor Nick Terry from IU McKinney School of Law and I wrote an article for Harvard's Law Blog about addiction during COVID, and some of the ways that policy has been changed in order to make sure people have access to treatment, some of the telehealth restrictions that have been limited, some of the changes to law enforcement, and people have been hesitant, or they are making adjustments to not leave people sitting in jails for minor crimes, especially during COVID because of the risk of death. There's some other things around access to medication. Buprenorphine and methadone both are very highly regulated medications, and it really doesn't fit. There's other medications that are much more dangerous without even a fraction of the regulation that they have. And luckily, because of COVID, some of that has been eased. Some of the state projects that we have going on. So remember that jail that I told you was ahead of the curve, that was doing a therapeutic community, and they were doing Vivitrol at the time. Well, their sheriff has continued to be on the front end of this. And again, I said at that time, just doing that one medication was considered forward thinking. Now, as he's continued to grow in this area, he was the first sheriff in Indiana to implement medications for opioid use disorder, including buprenorphine, and they're working on the methadone piece of it right now. And it's a good example also of how we can have an idea previously, we can digest new information, and we can change our position on something. The sheriff is a great example of that, and is happy to discuss his transformation on this topic of medication specifically. Part of this is directed. Governor Holcomb has dedicated $4 million in Indiana to do MAT or MOUD in corrections. They're working with the State Sheriff's Association to make this available to all 92 sheriffs in Indiana, clearly making it a priority. We know that when people leave jails, they're over 100 times more likely to die from an overdose. So when we're arresting somebody, if we don't give them medication, we're actually increasing their risk of overdose. Another training thing that we have going on in Indiana is Project Echo. I'm not sure if anybody's familiar with it. Again, there's a link on there. This is a model that was done out of El Paso, I believe, was the first place. I could be wrong, New Mexico. And essentially it's a virtual-based training for any set. We did it for providers for a period of time, and they just did a track that was dedicated to correction setting. I was grateful to have Matt on there as well. Costello was part of the training team for this to train well over 100 folks in corrections about doing medication inside of correction settings. And so I talked a lot about how my addiction broke my life down, how it ruined all my relationships, how it got me into jail, how it stunted me educationally and professionally, and how I was otherwise in a hopeless position before I was able to address those 4 areas that we talked about earlier. And I want to kind of recap what recovery has done to me personally, because the decisions everybody makes on this that are here today will impact people's lives. People here have the ability to make decisions within their agencies that can literally save people's lives, especially in this corrections area. Again, people are so likely to die from overdose leaving jail. We need, the same way that we would never send a severe diabetic out without their insulin, we can't send a person with severe opioid use disorder without medication. And so, you know, I joke a lot that for as much as changed, a lot still remains the same. You know, I still talk about drugs, right? But it's in relation to recovery. I still go to jail, and fortunately, when I go now, it's usually to help set up programs, and they actually let me leave when I hit the button. And I still stand in front of judges. But when I stand in front of judges today, it's not to answer for the crimes I've committed. It's usually to help train on substance use disorder, or to give a referral on a client possibly that I've had in some type of programming. And so, you know, education-wise, as mentioned, I was a high school dropout. In early recovery, I remember being at that treatment center, and I was probably about 3 or 6 months sober, and one of the guys that worked there, his name was Ben, never forget this, he was asking me about my education. And I told him that I didn't finish high school, and he asked me what I was going to do about it. And I kept kind of beating around the bush, and Ben said, you need to go back to school. And I finally told him, I said, look, I'm not smart enough. Like, leave me alone. I was really frustrated, and I could see him visibly get upset. Like, physically, I could see him like almost start shaking. And he was so mad at me for saying that I wasn't smart enough to go to school. He said, what are you talking about? You had severe use disorder during that time. You couldn't keep up with school because you were drinking during the week as a like a 15-year-old. Like, that's not normal, Brandon. You need to go and get this taken care of. And so I did. I went back and I got my GED, and then he said, you need to go to college. And I said, I can't go to college. I don't got any money. He said, well, come on. I'll show you how to sign up for loans and Pell Grants. And he did. He helped me get funding. Again, extra battle there because of my addiction, because of the stigma, because of discrimination. There's one legal question on the application at the college I went to, and it was, have you ever been arrested for a drug-related offense? Not did you murder anybody, not have you been convicted of violent crimes. Literally the only thing they asked about was drugs. And I didn't get into school for an extra 6 months because of all the documentation I had to provide to show essentially that, you know, I wasn't actively using drugs. And I certainly understand the need to keep our universities safe. But the idea because somebody uses drugs that they're dangerous is a false equivalence. It's a stigma associated. And so I was able to get back in school, and I got a degree in human services. I went back, I got that degree in addictions counseling, and I graduated with a 3.99 GPA. and Dean's List, summa cum laude, all the stars, the stripes, or the stars and whatnot. And so I don't say that to try to, prove to anybody how smart I am. I say that because I thought I wasn't smart enough to get out of high school. And what I found out is that I had that self-shame going on, or that self-worth issue from my substance use disorder. When I went to school and I applied myself, I actually did pretty well. I showed up when I was supposed to show up. I turned my work in when I was supposed to turn my work in. And I did pretty well. And I've found that to be the case in most situations. People always tell me when they're talking about a loved one, they say, "Oh, he's such a good person," and as if everybody's going to think they're a bad person because they use drugs. And what I like to tell people, and this is really important, I think, is that people with substance use disorder are not bad people trying to get good. They're sick people trying to get well. Right? Not bad people trying to get good. They're sick people trying to get well. We have to stop looking at this as a moral failing. We have to start looking at this as the chronic condition that it is, so that we can start seeing people as human beings again, and not just criminals that we need to punish. I used to pick my daughter up when she was young and I was still using. I would pick my daughter up. I would pick her up, put her in my car, take her to the bad neighborhood where I bought drugs. I would buy drugs, and I would do drugs in the front seat with my daughter in the back seat of the car. And that's still to this day hard to say out loud, but it's true. And it's a fact, and it's important to say because there's other people in that same situation. My brain at that point told me it was more important for me to use drugs than it was to keep my daughter safe. And so I'm about a year and a half ago, imagine this, 15 years later, I was able to go pick my daughter up, put her on a plane, take her to New York City so that she could watch her dad give a TED Talk on addiction. And if that contrast doesn't say recovery, I don't know what does. Throughout my recovery, she's lived with me twice. I've taught her how to drive. I've helped her sign up for college. And now she gets to watch her dad be healthy instead of sick. I've got a 5-year-old daughter that has never seen me use before. And she doesn't know any different. She can count on me to walk through that door every single day, and be there and be dependable. And a wife that I've been married to now for 8 years. And my life is completely amazing because of the treatment I received, because of the recovery I got. And my call to action for people on here is you have power to do this to people's lives. You have the power to help people find recovery, to help build an ecosystem and a system that is actually built for chronic conditions, where we help them along their journey while they address all these areas of life. And so I can't say thank you enough. I will try though. Thank you for having me today. Look forward to talking to everybody later on during question and answer. And that is all I have. Thank you all very much for having me.
So I want to thank Brandon for sharing his journey. I can say firsthand how much I know folks have benefited from hearing about Brandon's experiences. I want to thank the OTE team for creating a space to talk about those experiences, to share those experiences. Good morning, everyone. My name is Dr. Brad Ray. I'm the director of the Center for Behavioral Health and Justice. I'm very excited to see so many people tuning in to our second OTE Summit event. And today what I want to do is talk about what we see as some of the key components of a community's opioid treatment ecosystem. But first I want to start with a broad overview of where we are today with this overdose epidemic. And I want to start with this metric. I've been thinking a lot about this metric lately and becoming concerned that it's becoming normal in America, that more people are dying of drug overdose deaths than motor vehicle accidents. I remember where I was when I first heard this metric. It happened at different places in the country where you were, but I remember where I was. I remember that it is presented as sort of a call to action. Like, this is really happening. This is a huge problem. We need to do something about it. It was in the news and a lot of people were talking about it. And I think it was an effective call to action for people to see how serious this problem was. But I think back then when this occurred in our society, we didn't stop and ask for long enough period of a time, why are we comparing drug overdose deaths to motor vehicle accidents? And if we would have paused and we would have asked about that for a while, what we would have realized is that it's because they're accidental deaths. Drug overdose deaths surpass motor vehicle accidents as the leading cause of accidental deaths in our society. And the reason we call these deaths accidental is because they're largely preventable through policies, through individual actions, through regulations and other means, all right? And in all those years, when people were more likely to die from cars than they were from drugs, I never once heard as a singular policy solution that we need to get rid of all cars. Instead, we made cars, roads, drivers safer. And I'm hoping we can take some of that thinking into how we address this overdose epidemic going forward. The next thing I want to tell you about is that for the past over 40 years, actually, the United States has been seeing an exponential increase in overdose deaths. Each year, nearly twice as many people than the year before die from overdose deaths. And in 2018, for the first time in over 40 years in the United States of America, we saw a reduction in overdose deaths. However, this reduction was only experienced by whites in our society. We still saw increases in deaths amongst African Americans, drug overdose deaths. These largely occurred in urban areas with the co-use of cocaine and fentanyl. But I tell you this because it's very important that we switch this conversation from thinking about this as a white prescription pill problem to what is increasingly becoming an African American fentanyl problem. And of course, the societal problem having the greatest impact on overdose deaths right now is COVID. And I think it's going to be many years until we figure out the true impact of COVID on overdose deaths. But suffice to say, all of the preliminary evidence is suggesting large increases in both fatal and non-fatal overdose events. So as we've done this work in the opioid treatment ecosystem, as many of you know, a lot of our efforts have focused on jails. And the reason we focus on jails is because folks that come through these systems don't know that they have opioid use disorder. And as Brandon mentioned, they're at very high likelihood of death once they leave these incarceration facilities, all right? So we put a lot of our work into that space. And as those of you that work with us know, we're not trying to just get one medication in there to sort of check that MAT box. We're trying to get all 3 FDA approved medications in there. Buprenorphine, which you probably know by Suboxone or Subuclade, methadone, and naltrexone, which you probably know by Vivitrol. I'm not a medical doctor. I've never prescribed any of these medications, but I will say as a researcher, the comparative effectiveness studies are suggesting that buprenorphine and methadone are more effective than naltrexone. So that's some of the research we see coming out. And so we feel it's important to have all of these medications available so that there's some choice for clients as they're coming through these systems. But as you know, it's not just about the medications. We're trying to get jail facilities so that they're screening individuals, identifying those who have opioid use disorder, who are going through opioid dependence, to have all of those medications available, ideally with new inductions for folks that are being identified, the adjunctive psychosocial services for folks that are getting these medications, and even for those who are not receiving medications, but importantly, a continuity of care plan that happens at that booking process. And so that when folks leave the jail facility, they know where they're going to be going to continue to receive those medications. But as we do this work with the opioid treatment ecosystem, which is what we do in any of the work we do actually at the center, we use the sequential intercept model as a way to think about where we can leverage and expand our impact. So within the sequential intercept model now, we're working, the OTE and MOUD program works very heavily at that reentry level. We have other initiatives in the center, the Mission MyRep program, that's peer supports at reentry. We do jail diversion work that operates more at that intercept 1. But throughout this sequential intercept model, we're trying to identify ways that we can strengthen that opioid treatment ecosystem. And today we're going to talk about a program that's been developed and championed by one of our own folks, Leonard Swanson, called PROACT. And this PROACT program really, in many ways, exists outside of criminal legal systems. And it's operating in the community at that first intercept to divert people into treatment before they have involvements with the criminal legal system. And in thinking about that, and thinking about how this opioid treatment ecosystem approach that we have is moving outside of the criminal legal system and into emergency medical responders, which we'll be talking about later today, I want to talk about a part of an opioid treatment ecosystem that is crucially important to any community, and that's harm reduction. At its core, harm reduction is a philosophy. It's a way of thinking about problems. When we can't get individuals or societies to change behaviors, or individuals don't want to change behaviors, we think instead about how do we reduce the potential harm from those behaviors. As I talked about earlier with cars, as we saw car accidents increase, we now we enforce seatbelts, we enforce helmets. I've been working with my daughter all summer to put her into the very dangerous reality of riding a bike, and in doing so, telling her over and over again the importance of having a helmet. This is harm reduction, this type of thinking. But when harm reduction goes from a philosophy to an actual practice where people are boots on the ground actually doing activities where this philosophy has become embodied in a program, no more embodiment of harm reduction has been more effective in our society than syringe service programs. Syringe service programs, I need to tell you though, importantly, they operate very similar to a seatbelt and other harm reduction initiatives, actions, if you will. They work best if you have them in place before the accident occurs. Putting on a seatbelt afterwards is not going to help you at all, and having a syringe service program after an HIV outbreak, similarly, is not what we're looking for. If you're asking right now, does my community need a syringe service program? The answer is probably yes, to divert a potential outbreak. There's many myths about these programs, and not all of them are the same. But the evidence, we've had these programs since the 1980s, that we know that they have massive reductions in HIV in our society. But also, they're more likely to get individuals into treatment, reduce subsequent drug use. They're more likely, when we actually do the studies, people are likely to, there are actually less needles in communities. And of course, the cost effectiveness is simple to calculate. One needle could reduce an HIV outbreak by reducing folks from the potential of sharing them. So these are a very big part of harm reduction, syringe service programs. But I also want to tell you about a new emerging practice in the United States that incorporates harm reduction into community-based treatment. This is called low-threshold buprenorphine induction. It's also referred to as medication first. Some of the folks here, we put this model has been adopted from a study. I think they've done a great job of explaining the difference between what a low threshold and a traditional buprenorphine experience might be like getting this medication. But as you can see there, folks are able to get the buprenorphine immediately without going to multiple office visits within that same day, and even potentially through a home induction that through COVID now, folks can get buprenorphine prescribed over the telephone. As you can see there, though, the patient goals are prioritized, and the main goal really that they're hoping to aim for is for individuals to reduce their opioid use. So unlike traditional settings where individuals might co-use substances with buprenorphine and have the buprenorphine cut off, in these low threshold programs, that doesn't occur. Similarly, in traditional settings where the intensive counseling is required, in these low threshold programs, it is recommended. There's several different programs that are hopping up across the country. There's some really interesting homeless outreach work going on in San Francisco. In Baltimore, there are efforts to have these low threshold programs outside of jail facilities. In Chicago, a friend and colleague of ours is working on getting folks into buprenorphine treatment immediately from a harm reduction site. So there's a lot of activity occurring around this. And I know one of the things that comes up with folks, especially around buprenorphine, is diversion. And I'm not here to say diversion isn't a problem. It absolutely is. I'm here to contextualize it. Diversion is a problem for every single prescription medication in our society. We're constantly trying to figure out through regulation activities, how do we reduce diversion? In particular with buprenorphine, though, the studies that are out there suggest to us that folks that have an opioid use disorder that are misusing or using non-prescribed buprenorphine are often doing so because they can't get it out through regular channels. They're not tending to use these substances to get high, but rather to maintain their sort of clarity and getting into recovery. What we also see in the research is that even when buprenorphine is non-prescribed, and folks are using non-prescribed buprenorphine, there's still reductions in illicit drug use and overdose. So again, we use this website StreetRx sometimes to look at the cost of illicit drugs in our society. And as you can see, buprenorphine is on there. Viagra is on there. Adderall is on there. All of these prescription medications are diverted. And so I point this out because to me, I don't think the diversion of buprenorphine, the gold standard, through all these comparative effectiveness studies showing us the gold standard treatment for opioid use disorder. And we're not allowing that because of our concern over diversion. At a time when people with opioid use disorder are dying in the tens of thousands. This is the gold standard treatment for this disorder that many people are dying of. And if we put any other disorder in there, we would never let these concerns about diversion become this big of a barrier. And so I point that out as a potential barrier for people to think about and to contextualize. The last thing I want to tell you all about is an evolution to our opioid treatment ecosystem community of practice process. As some of you might know, for the past year, we've had folks at our center working with 5 or 6 counties in the state as part of having these community change teams. So they work with local stakeholders to implement medication-assisted treatment in jails. And what we're going to be doing going forward with this event is having this as a monthly community practice event. So each month, the 3rd Friday of each month, we're going to have those stakeholders coming together to talk about some of the barriers they've overcome, some of the successes they've had, so that those agencies, those counties, those stakeholders that are exploring or preparing to implement a program like this can listen in, and that ideally by having these events virtually, the CBHJ can facilitate offline conversations to overcome barriers, help people figure out what are those first steps to getting medications and getting a program like this developed in my community. What we're also going to be talking about on those community of practice events is one of the most innovative programs that we have in our opioid treatment ecosystem, and that's PROACT. PROACT gets at people at a very, very important touch point, following resuscitation with naloxone or other means of a non-fatal overdose. Leonard Swanson has created and championed this PROACT model in our center in a really admirable way. He's diligently facilitated conversations between stakeholders and really helped to identify some of the key structural barriers that would be in place when people want to take that first step to get something like that started. So I'm really excited for Leonard and the team to talk about the results from the PROACT initiative today, and I'll let you all take it away. Thanks.
Thanks, Brad, for the kind introduction, and thanks to Brandon George again for the really moving talk earlier today. You know, as a researcher, spent a lot of my time looking at research, statistics, and to really see that come to life in a story is moving. So thank you for your time today. So what I want to talk about today is PROACT programs. So PROACT is an acronym for Proactive Response to Overdose and Appropriate Connections to Treatment. And why we want to talk about what happens after initial overdose is, well, high risk of death. Death is exactly the kind of thing we want to avoid. So in the year following a non-fatal overdose, there's good research out there saying you're much higher risk of death, either through a subsequent overdose, after the first one, or a number of different medical causes of cancer, suicide, respiratory diseases. And it's particularly true for opioids. So for those who have repeated non-fatal overdoses, you know, chances are high that one of those non-fatal overdoses are going to end up becoming fatal. And unfortunately, this is ever more true during the COVID pandemic. So right here we have data from the University of Michigan System for Opioid Surveillance. They do great work in collecting data across the state for both fatal and non-fatal overdoses. And for folks on the line that are stakeholders in this space, they're really open to working with you directly to look at data in your local area. But unfortunately, we are seeing drastic increases in recent months. So on here are two line graphs over time. The red line graph is what's happening in 2019. And unfortunately, this blue line of fatal overdoses is 24% higher than the same period in this gray COVID box that we're living in now. And so this is from medical examiner data on the left, but then also true of non-fatal overdoses measured by EMS and naloxone administrations. So on you can see the 2019 graph, about 200 to 250 per in the state, and then even higher in 2020. So this is ever more of an issue now. Go back a slide. So we can also see this over space. So you can see in our populated areas here, looking at Kent County here on the west side, and Detroit, and Wayne County and Oakland County here in the southeast, we are seeing higher percentages of fatal overdoses, and pretty much throughout the southern part of the lower peninsula here. And there's some cities over here if you want to learn more about your local area. Again, the SOS has been giving us really valuable data to look at, but it really tells the story that we're in a opioid crisis right now, and in addition to the COVID crisis. So I want to talk a little bit about what happens during a typical first response. So if someone does call 911, and I recognize it's not always the case, there might be someone on the scene administers naloxone and they're scared of calling 911 for fear of law enforcement response and charges and whatnot. But if we are lucky enough to receive a 911 call, we do have a first response. So police, fire, and EMS typically are on the scene, and whoever arrives on scene, it kind of depends on the region you're in. So in metro areas, we're likely to see an EMS service, emergency medical service, arrive first, whereas rural areas, more often you're seeing law enforcement on the scene first. There's generally more patrol cars out there. And so why is this important? So whoever on the scene, it's best practice to have naloxone or Narcan available to reverse that overdose. And unfortunately right now, not all police or fire departments or even EMS departments have naloxone or Narcan to reverse that initial overdose. So before I even talk about what happens after the first response, I still want to beat this drum of we need more naloxone and Narcan in our communities to save lives. It's really that simple. And ideally, a transportation to an emergency department afterwards. Though 10% of naloxone patients don't even make it to that step. So what is naloxone? What is Narcan? Why is it so important? Well, during an overdose, your central nervous system shuts down. So you kind of need to breathe and have consciousness to be able to be alive. And so naloxone works as an antagonist to block the receptors and then allow the brain to resume normal functioning. But why I talk about it's so important that our first responders carry naloxone or Narcan is that it has to be introduced to the body really quickly. We got a 1 to 3 hour window to that naloxone Narcan can make a difference. And maybe it takes a little while for someone to recognize a possible overdose. Maybe there's some period of doubt before they call 911, before the first responders on the scene. So it's really hard to tell how much time we actually have. So whoever has the ability to arrive on the scene first, very important that naloxone is administered. And there's really no risk. If opioids are not present, naloxone and Narcan does not have an effect. I saw a news article that they were teaching 5-year-olds in Tennessee how to use the nasal spray naloxone. It's really that simple, and it's really low risk, and it saves lives. So after this first response is what our program of PROACT is really targeting. So, and again, individuals who overdose the first time, and heroin in particular, high risk of a repeated fatal overdose or a non-fatal overdose. So hospitals and emergency departments can provide resources and do. Oftentimes a referral card is passed out. But we're really struggling on this piece below of how to get our treatment partners involved with the person. So I'm even going back to the slide. Where's our treatment partners on here? We have first responders, we have the emergency department, but at no point in our typical flow of first response Are we involving a treatment partner to really follow up and give that ongoing care? It's as if someone has an emergency medical procedure and we're not providing a referral or direct connection to treatment with ongoing physical therapy, even though they might be at higher risk, even if they don't engage with ongoing care afterwards. So this piece of ongoing treatment connections is missing in a lot of parts of the state. And why we're stressing this so much is folks who survive overdoses are more likely to engage in treatment if they speak to someone about it. So speak to someone, could be a clinician. A lot of the evidence showing a recovery coach who has walked the walk and can really speak from experience about what it's like to start on the journey of recovery are effective. And providing a direct connection to treatment, not just a referral card, more likely to get someone engaged in care. So we believe there's a real opportunity here to involve our treatment, recovery coach, and harm reduction partners in this model of first response. And our goal is to establish that really direct connection. We started in Kent and Monroe counties, where I'll introduce both our treatment partners there. So here's the model of what we think should be happening. We have fire, EMS, and police arriving on the scene, and we have our treatment partners here, and they should be getting notified by someone on the front lines when an overdose case happens. If they're able to get the response quickly, ideally our treatment harm reduction partners can, if they have the capacity, can meet someone at the emergency department or follow up at the home the next day. And offer a variety of services, really depending on what the overdose victim is ready for. They can offer naloxone kits and training. There's syringe service programs that Dr. Ray was talking about a little bit earlier, and treatment services depending on the stage of change. So what do I mean by stage of change? Well, it's critical that we underscore this point that someone who's in active use might be at what we call a pre-contemplation or contemplation stage, where they may not be, invested in treatment at that point or invested in recovery at that point, and may only be open to baby steps. It is a giant step to do the research of who's your local treatment provider, what's your insurance system look like, how are you going to get a ride there, how are you going to plan around work, and if you're worried about confidentiality, working around those hoops as well. There's a lot of trust to build, whereas, accepting a call from a recovery coach or a treatment system may be more receptive, maybe just opening the door if someone's willing to speak with you in that way. So instead of having relying on our folks to actively seek treatment, arrows going from person to our little brain and a plus here, we're trying to get our treatment systems, recovery coach systems, to be proactive and meeting the people physically where they're at and on recovery where they're at. But of course, that's our ideal, and there's a lot of barriers in the way, as you can possibly imagine. So for one, it's not like there's just one law enforcement agency to receive referrals. It's not like there's just one fire department to receive these referrals. A given county might have 5, 17, 42 law enforcement agencies to work with, and that's kind of a headache to get everyone on board. Fire, there might be just one for your municipalities, your cities, your townships, a lot to work with. And even at EMS, there might be 1 to 3 different EMS providers in a given county, or even emergency departments. I didn't list it here, but there might be 5 different hospitals to go to try to get these referrals. But we're stressing the EMS connections here because they cast the widest net and administer more naloxone than these other parties. And we'll have some data that talks about that in a second. But the bigger issue that we've been really honing in on for the last 6 or 7 months, and I'm sure anyone in the behavioral health world already has their ears perked up to this, is data sharing laws. HIPAA, 42 CFR, Michigan Mental Health Code, HIPAA being Health Insurance Portability Accountability Act. A lot of these legislation in place to protect the names of individuals who want to seek treatment, that want to avoid the stigma. And for many good reasons. But unfortunately, these days, these laws are not well understood, even in the treatment world. So there's even research showing that's coming out. Most err on the side of caution and overly restrict access to care and to this identifiable data when they don't need to. And I understand that there's an importance of confidentiality here, but if we're not making these treatment connections, then we're ending up in our system where the treatment provider, recovery coach providers don't know that overdoses are happening. We don't know about this high risk of subsequent overdose. And we're left, turning the wheel of emergency response without getting a more sustainable and really effective system in place. So without really digging into the laws and learning about what's possible, sending identifiable information, we're really limiting our opportunities for case coordination that can save lives. So really, I want to talk about the laws we've learned. This is a section where it can get pretty dry, I admit. But this recent ruling, we worked with the EMS legal representation from both Life EMS in Kent County and Monroe Community Ambulance in Monroe County. And they both agreed that the laws I'm about to highlight today allow direct referrals from EMS agencies to a recovery coach and treatment providers without collecting consent on the scene. Now, the collect consent on the scene is pretty important right here. We even tried for a couple months up in Kent County where EMTs would try to get releases of information to collect on the scene. If someone's just been revived from an overdose, they may not have the wherewithal to make those kind of decisions. We know that substance use disorder can impair judgment on the scene. And, if you're just being revived in an overdose, you're probably not likely to want to sign something on the scene. So we tried the route before we really understood the legal ramifications of it. And trying to collect consent on the scene was not feasible. So we dug into the laws a little more and we found out that yes, we can send these referrals without collecting consent. So under here, under the EMS, we highlighted the laws at play here. You'll note that HIPAA and Michigan Mental Health Code, the EMS has to abide by, but 42 CFR Part 2 is not one of these laws. So 42 CFR Part 2, for those who don't know, are a stricter federal law about patient identifiable information for substance use treatment agencies. And the reason they don't apply to EMS is that EMS agencies are not federally assisted, nor do they hold themselves out as behavioral health treatment providers or substance use treatment providers. So, and you would have to be both of those things for 42 CFR Part 2 to apply. So EMS only has to abide by HIPAA and Michigan Mental Health Code to send it to either CMH or a provider organization. And so here are the laws here. CMH agencies have an extra layer of legal protection in that they're a public health authority for the purpose of preventing injury. So especially in the case of COVID, where we're trying to do contact tracing, we kind of need to know the names to prevent further injury. Similar reasoning for opioid injury. You're allowed to send the names to a public health authority for the purpose of preventing injury. But even more basic than that, for the purpose of treatment activities of a healthcare provider, or in Michigan Mental Health Code, there's another law on the books there, to a mental health or public agency on a compelling need based on a substantial probability of harm. So I've talked a lot about how that initial overdose, you're at much higher risk of encountering a second, 15 to 24 times higher risk of death. I would say that's a compelling need based on a substantial probability of harm. So under HIPAA and Michigan Mental Health Code, EMS agencies can send information to CMH. And even a provider too. These are the same laws as over here. They don't have that extra layer of protection for the public health authority, but the referral can still take place with the names without consent. So again, for the purpose of treatment providers, treatment activities of a healthcare provider, and on a compelling need based on substantial probability of harm. So for example, if I, Leonard Swanson, encounter an overdose and EMS agencies have that treatment record of my phone number, my contact information, address, they're allowed to send that to either the CMH or a provider like the Grand Rapids Road Project. If the purpose is they can do a follow service. And of course, us as researchers, we're allowed to collect the identifiable information for research, audit, and evaluation purposes. So why am I stressing EMS referrals so much? Well, the EMS agencies reverse a lot more naloxone administrations than law enforcement or fire alone. So when we started out this program in Monroe County, they were only receiving referrals from the Monroe County Sheriff's Office while we were trying to figure out the legal pieces. And you can see this yellow line, maybe one referral a month, maybe two referrals a month, whenever the sheriff's deputies would administer naloxone. But we had to check against that, and we knew that the non-fatal overdoses were much higher than that on a monthly basis. So this is coming from EMS naloxone administration data, again from the UMN SOS. There was about 15 a month, and then COVID increased to about 20 or 30 naloxone administrations a month. And then once we got the legal decision, really about a month ago, really recently, the EMS referrals, just a huge increase, right? We have way more people coming into treatment and recovery coach option of Monroe Community Mental Health Authority. So these EMS referrals can make a huge difference in a number of people at least getting access to care. Of course, I'm a researcher and I'm in a data position, so I don't know what it's like actually after the referrals take place. So on this, I might turn to my colleague, Adam Anastoff of Monroe Community Mental Health Authority to talk a little bit about what happens after a PROACT referral. So Adam, if you're here, I'm wondering what you all like to do after that.
Thanks, Leonard. Yeah, we've had the opportunity to partner with Leonard and CBHJ to dive into this project, and it's been pretty exciting. We, as the chart had showed, we pretty recently we started receiving a pretty good number of referrals. Up until that point, it was fairly slow. We would still respond, but we didn't have that many referrals to respond to. When we receive the referrals, the way it works for us is we have our team, we ensure that the communication is being made among our team internally. And then the model we're looking at right now is we have our clinician who initially responds. And due to the COVID restrictions and stuff at this time, primarily that response is a phone call. So we're trying to connect over the phone, which has posed a barrier. And I'll talk a little bit more about that. But even with the phone contact, we've been able to make some contacts. And from there, we're able to engage in a conversation. That conversation is using a lot of motivational interviewing to try to move people through stages of change, as was mentioned, and try to see if there's any interest at all in engaging in any kind of treatment. It could be anything from outpatient treatment to detox to a recovery housing, even behavioral health. So anything, obviously, person-centered, whatever they're willing or are interested in doing. And maybe they're not ready at that time, and that's often the case. And so what we're doing is just, again, engaging in conversation, trying to build some rapport. And from that rapport, then we'll do some further follow-up. So further follow-up could come from the clinician again, or a lot of times we're also implementing and utilizing our peer support services to engage. And hopefully, if the engagement wasn't great with the clinician, peer supports can engage on a different level. And so hopefully they can connect. And if that happens, again, we're just trying to break down barriers and move toward, move toward getting them involved into some kind of treatment. So I think that the numbers are exciting, as was shown there, and we've been able to get some positive numbers in people involved in treatment. But I think even more exciting is that we we've only just scratched the surface. I mean, we really haven't, we have more ideas on how we can engage people. We're always looking and trying to be creative in doing so. Here in October, we're going to start trying to make face-to-face contacts again to try to help and maybe boost some of that engagement and rapport with people to see if we can get some more movement that way. But I think it's an exciting venture, and we're happy to be a part of it.
Yeah, thanks, Adam. And of course, we're really excited too. And I wonder if you could speak to some of the challenges that we've been through in implementation, if we haven't already, and then maybe some success stories of cases you know where you're really able to connect and see some positive change.
Yeah, I think that the challenges, one, for example, is the phone calls, right? And having restrictions and going to people's homes because you don't always have a good number or a valid number or a number at all that you can contact somebody by, which obviously poses big problems. And if you do have a valid number, whether or not they're going to answer, you know, if they don't know I mean, personally, if I don't know the number, I'm not always answering my phone. So that's a barrier. One of the barriers, obviously, as we highlighted was, as Leonard highlighted, was getting all of the agencies on board with sending the referrals over. The Sheriff's Office, obviously, we work with them pretty extensively, so there was no barrier there to get referrals from them. But the referral number was pretty low. So once we were able, and you know, a lot of kudos to Leonard and his team to be able to get EMS and research all those laws and educate them on those laws so that we could get those referrals going with EMS. That was taking down one of those major barriers. And now we have access to a lot more information that will allow us to launch into the community and try to help more people. Yeah, and I think, I mean, you know, we were in conversation as a team with Leonard and with Kent County to try to brainstorm and be creative in how to approach a situation with making sure we're maintaining people's confidentiality. And, you know, I mean, not everybody, you know, people don't want this to be known with other family members, so trying to skate around those types of things. And so, you know, we were working on that as well. And I think we've, you know, come up with some good interventions in that regard.
Yeah, thanks, Adam. And I think we've really excited about the progress, and of course, more to learn. You know, we'll be continuing to work out, you know, how can we make that usable contact information from the EMS, you know, how do in-person visits work out, but really excited to where things are going in Monroe. So I might pivot to Kent County, our other sister county that we're working with to get these kind of PROACT referrals going. So the Grand Rapids Red Project has been doing this work even before we joined, where they have established a number of connections with their local law enforcement in their area, so including Grand Rapids Police Department, Kent County Sheriff's Office, and others. And we've been working over the last 6, 7, 8 months of trying to get EMS partners on board. And thankfully, literally within the last week, we've had some movement on a memorandum of understanding with Life EMS. And again, coming out of that legal opinion of, you know, their legal folks said this was okay. So we expect to see this referral line really have a sharp increase, probably around September, October is when we're getting going. So similar chart, you know, this green line would be the non-fatal overdoses we're seeing on the back end, and yellow line referrals in place. But I want to say probably won't get to the top line immediately because, well, like I said before, there's a number of different parties here. So and Kent County has 3 different EMS agencies. There's Rockford Ambulance, which covers kind of the Northeast Territory and the Northeast and mainly rural area. There's American Medical Response that covers kind of heart of Grand Rapids and some other areas. And then Life EMS, the partner we've been working with most closely with, that's really been a trailblazer for us in this regard of really expanding their scope of work in working with us to get these referrals going. So we anticipate about 40% of the naloxone administrations of Kent County will be able to get in the hands of RED Project for these follow-up referrals. So I'd like to invite our friends Megan and Josh from the Grand Rapids RED Project to talk a little bit about what happens after they receive a referral. So Megan and Josh, take it away.
Hi, Leonard. Yeah, so I'm Megan. I'm our program manager at the RED Project, and this is Josh. He is our recovery coach. And so when we get a referral from law enforcement, we get that report when they have a Narcan deployment, and then we put on our detective hats and kind of do an admin work prior to going out, and just kind of getting as much information as we can. And then we do in-person follow-up. So we're doing wellness checks at the individual's house or resident location, just meeting people where they're at. And so generally that's with 1 or 2 staff members that will go out to provide those in-person wellness checks. And then when we're there, we're just making introductions, and just assessing the needs of the participant at that time. The RED Project, we work really uniquely in that we approach individuals at any stage of change. So we offer a variety of services to kind of encompass people who use drugs and meeting them where they're at. So that can be anything from overdose education and naloxone, can be our syringe access program, so getting people involved in that to reduce the risk, as we learned earlier, of like HIV, Hep C, even any type of bacterial infections. And then we also have recovery coaching, where Josh comes into play with that. And again, just meeting people at any stage of change. And just identifying barriers or creating goals for individuals. We also provide more in-house the rapid HIV and hepatitis C testing, along with linkage to care. And then we also encompass risk reduction counseling with individuals of how can we provide the resources and tools to reduce whether it's HIV, hepatitis C, overdose from occurring. And then we do just general linkage to care within the community. And we try to get participants engaged in groups, whether it's with RED Project or community groups as well, is kind of how that all looks like.
Great, and I'm really excited that more people are going to be able to receive these kind of services once the EMS agreements are worked out here any day now. I'm wondering if you could talk a little bit about the challenges you've had with establishing the program so far. I mean, you've been doing this longer than anyone I know in the state. So how has it been a struggle, and what have you done to overcome it?
Yeah, so I guess when we first started the program back in 2017, prior to starting the program, we had already had a working relationship with law enforcement, and that we had already provided training and equipped law enforcement officers to respond to an overdose using Narcan. So with the program, the goal of the program was to kind of build that gap with community members and providing that linkage to care, as not everyone may go to an emergency room for treatment. So just trying to build that gap and really get people connected to other resources and community, even if that's not necessarily treatment, like an abstinence-based program, but just getting involved in harm reduction practices. So some of the challenges that we've seen, similar to what Adam was talking about a little bit earlier, is just referrals can be a challenge. And so I'm really excited that we were able to work together to try to overcome that with getting more referrals from EMS, as right now our program has been mainly focused on reversals from law enforcement, but now we can focus as well as those EMS referrals come in as well. And then,
yeah, so I'm Josh, I'm a recovery coach. I primarily do the follow-ups, and the one barrier that I've noticed the most is the initial contact, simply because an incident address and a resident address that were provided, incident addresses can tend to be parking lots. So that's not much help. And then a resident address, you can tell it may not have been an individual's first rodeo because they provide an address that might be in another abandoned parking lot, or where there's no home at all. Like you get an address, you go there, and the number doesn't even go to an actual residence. So that initial contact has been the biggest barrier that I've had.
Yeah, it would be definitely great to increase as many folks as we can to get this program, but sometimes the information is as good as you can get. So I'm wondering if we could ask one more question of what are some success stories that you've had? I mean, you've worked with a lot of people in this way, and I wonder if you could kind of close out this part with.
Yeah, I've worked closely with some individuals, and so one of the best, success stories we've had is there was an individual who was abstinent for, about 7 months. And then when COVID hit, he had lost his job, was kind of isolated, kind of idle hands situation. And he had overdosed 4 times within the span of, I would say, 2 to 3 weeks. We followed up with that individual, and he, working with him on a consistent basis, he eventually got on a Vivitrol shot, got back into working full time, and went from having not even seeing his kid to having visitations with his kid. So that was it was a pretty big turnaround, going from not using to overdosing to now on a Vivitrol shot, seeing his kid again, and working full time. So that was a pretty big success story.
Yeah, and I would just like to add that how we measure success at our project's a little bit different than maybe most agencies, as we just define it as any type of positive change that anyone is implementing or engaging in services.
That's awesome. Really excited that you're already doing this work, and then really excited to see how it transforms once we get some more people flowing to you. So thank you for not only being with us today, but your continued services. So I know we're a little bit past a half hour, but I'll just wrap it up by saying, these referrals are possible. Police, EMS, fire, this legal decision from legal EMS really allows us and opens the door for a new pathway to treatment. I encourage EMS agencies who own this critical naloxone administration data to work with your local partners to facilitate these pathways to care. And I know they're not always comfortable with the HIPAA 42 CFR area, which for good reason. They're used to taking folks to the hospital, and they use those emergency clause, and they don't really need to collect releases or what have you. But these referral pathways are allowable too. And so, we can help facilitate that change for any other county stakeholders across the state. Happy to help, and please reach out if you want to connect, and we can talk a little bit about how we've managed to make this work. And I'd be remiss if I didn't thank all our partners here. If we did not get the leash and the leeway from the Michigan Health Endowment Fund to really explore this issue and possibility, I'm not sure we would have seen this huge system change that we believe is possible. Again, thanks to Dr. Fales, the head of EMS across the state, for facilitating those EMS connections, and Amanda Kogowski at the U of SOS for their statewide data, Medical Control Authority of Kent County. Big thanks to our EMS partners at Life EMS and Monroe Community Ambulance, of course, Red Project Network 180, Monroe County Sheriff's Office, Monroe CMH, and of course our folks at the WSU team. And so with that, I think we can turn back to Matt Costello for question and answer.
Thank you, Leonard. I appreciate it. I first also want to just thank our presenters today. It's tremendous information. The progress that has gone on, both from in-jail service and then this first responder piece that Leonard has talked about, is tremendous. As Leonard mentioned, I am Matt Costello. I'm a project manager of the Opioid Treatment Ecosystem within the CBHJ. At this time, we are going to provide an opportunity for attendees to ask questions of our presenters. If you haven't already done so, please enter your questions for our presenters in the Q&A box located in the bottom of your screen. If we don't have time to get through all the questions, our team will compile responses to any remaining questions and then email them to you after the event. So thank you very much. The first question I have here is for Brandon. Excuse me. You mentioned talking about living in a recovery residence and, and as part of your recovery process. Many recovery residences are anti-medications. Did you find that barrier in place, or was there ways to work around those barriers for recovery residents and being on medications?
I was really fortunate. The recovery residence place I was staying was attached to the treatment center. It was part of their system, so it was allowed. But the person who asked the question is absolutely right. It's a big issue in Indiana. It's been a big issue. I know that we've done a lot of training in recovery residences, and actually now here, if you receive any type of funding from the state or federal government, you have to take medication. They did a bunch of training to make sure people were trained to do so. You can't just say, "Hey, here, do this," even though you're not trained to be able to oversee that. But they see it, the state sees it as a violation of the Americans with Disabilities Act. Recovery residences, if they single a group out and don't allow medication, that they don't think that they're complying with law. And so there's been a pretty big shift here, but it's still a big problem. I ran into it in other parts of my journey, just not during that phase of it specifically.
Very good. Thank you, Brandon. This question is for Brad. If a community, what can a community do if they are interested in starting a syringe service programs? Are there specific guidelines or resources that you can recommend?
I think the first thing any community should do in this is talk to their local health department. Your local health department should be able to identify where those syringe service programs are, if there is one, in the steps to starting one. I know that there is a division in the MDHHS that also they provide some state oversight of where the syringe service programs are in the state.
Could you explain a little bit more for me, Brad, what actually a syringe service program actually is? I mean, I think it's implied in its name, but I'm not sure how it's actually operationalized.
Yeah, so I'll just mention this is kind of where I got my start into this line of work, was volunteering and doing research at a syringe service program. People will talk a lot about the materials that they'll provide there. Obviously clean needles, other additional supplies so that folks can reduce the potential harm from drug use. But one thing that really just doesn't get talked enough about, and it sometimes sounds corny to say, but it's these places give people a legitimate second chance. They give them hope. They're the first time that people have really started to show concern about their health and their well-being. So that's why we do see folks, when they get into these syringe service programs, injection drug users, having these increased rates of getting into treatment or reducing substance use, just from the sheer making a connection with somebody. So yeah, they'll offer syringes, they'll offer condoms, other supplies, and then oftentimes referrals directly to providers.
Thank you. Leonard, this is a question for you. Is there any, the first responders that you talked about, there's about 10% of individuals who choose not to go to the hospital. Are first responders leaving any Narcan kits behind for those individuals, or for the individuals that might be part of that SAVE process? Is there any programming like that going on?
Yeah, so we know of, we've heard of some law enforcement agencies doing that, and there's particularly a movement on the EMS side, on the state, to establish leave behind programs. So the state recently advanced a protocol that the different medical control authorities at a local regional level can choose to adopt and leave behind a naloxone kit, which we fully support. Though I also say the PROACT model of introducing a person-to-person connection, really does increase the likelihood that someone wants to engage in recovery beyond that. So I definitely encourage leave behind naloxone, but I also encourage trying to make these in-person connections happen too.
Thank you. I appreciate that. Brandon, this question is for you. You mentioned that you're working with one of the most progressive counties in Indiana and is working toward introduction of methadone. It made me realize how progressive our jails are in working towards all three forms of medications now. Brandon, can you provide some perspective for our jails or local teams about how a state of the art of their work is and how maybe a count of the MOP, Health Fund, and other CBH communities in terms of how they're committed to going to all three forms of meds for treatment?
Absolutely. So it's really critical that people with opioid use disorder have access to all three medications. I think Dr. Ray laid out what the research said very well. But we also want to have informed consent, right? We want patients, we want people inside facilities. You know, for some people, buprenorphine may just work better than methadone. This is like a unique area. Like, so I don't want to get too far in the weeds, but you know, if you go to your doctor and you've tried maybe depression medications, the first thing they usually ask you is like, what have you tried and what works well for you? And then you tell them what works well, and they usually go with that because it's your preference. And we don't do that with this, right? We want to say, oh, we should use this because it's non-narcotic, or we should use this because you don't want to be on a full agonist, or whatever the things we tell people. And so, but the transition problem is really hard as well. And so it would be inappropriate to start somebody on methadone in a community and have them go back to an area where methadone wasn't available. And so there's a lot of coordination that has to take place. It's also legislated, right? Remember that high level of regulation. You're only allowed to have so many opioid treatment programs in Indiana per the legislature. And so that affects who can dispense it as well. And so, yeah, you have to apply for a special license, or there's a carve out to become I think they call it a window or forget the technical term. I don't want to misspeak, but there's essentially a waiver to allow you to do it off of somebody else's license. And that's what this county specifically is trying to do. And in this case, there's a methadone clinic within 20 miles, I believe, of the jail. So the setting allows them to get people started possibly. And then if they are staying within, the donut counties of that area, allows them to get connected to the existing opioid treatment program that will have all the other wraparound services as well. Another piece of that is really, we can't be planning for people when they're leaving. We need to start planning the minute they walk in the door, right? Right when they walk in the door, there needs to be an SBIRT or some brief interaction tool that identifies, do they have substance use disorder, can immediately get a coach talking to them, that can immediately start protocol for withdrawal if needed, et cetera. And then that's going to start driving the rest of those decisions that we're talking about. So it's a pretty nuanced process. There's a lot of components to it.
Yep. Just as a follow-up to that, Brandon, again, one of the questions we get from some of our sites is duration of time on the medications, particularly the jails. Again, it's new to them, right? The initiation and starting of this program is a big reach for them. And then the idea that an individual might be on a particular MAT medication for some years. Can you talk about what a length of time a typical treatment might look like for an individual on meds?
Absolutely. So one of the things we always talk about is individualized treatment plans, right? And then we put the person in the same cookie cutter approach of they should do X, Y, and Z. And medication really needs to be in between a patient and their doctor on making a decision on how long medication is appropriate. The data says that the longer the person stays on, the better the outcome, period, end of story. And actually, I think, and Dr. Ray can jump in, but there's some 3 and 6 month studies that actually say that when they're that limited, it doesn't nearly have the same positive effect as if they stay on for a longer period of time. And so as long as they need it is the answer. And we see this happen a lot, and I'll use depression because it's something everybody can understand, is people start taking a depression medication and they start feeling better, right? And then they start questioning, well, I'm feeling better. Do I still need this? And with the addiction piece, it's not just them, it's everybody in their life, right? It's the probation officer, it's the jail, it's the mom, it's the wife. It's, hey, you're doing so well. Why do you still need that medication? Instead of looking at it and saying, wow, they're doing really well in part because of the medication. And so the risk reward here, when you're talking about the mortality rates where they're at, I just can't justify a good reason to pull somebody off medication when one of the possible negative outcomes is death.
Absolutely. Thank you. Then a question for Brad. Could you talk about the number of counties that the CBHJ is involved with in terms of a full MAT programming?
Yeah, so just to kind of give a broader picture of it here, one of the things that we've done in Michigan is started by identifying those counties that were already doing some of this program. So Oakland County, Eaton County already had some programming for medications inside of their jail facilities. And we started out by visiting, learning a lot from what was happening there. From there, we've created this model, which is based largely on what we learned there, what was in the evidence. And we've been doing that with 5 communities now for the past year. Our hope, though, is through the SOR2, what we're going to be doing and through this broader community of practice is branching this out to the rest of the state. Other jails, other community partners who are interested in, and really, like I said, trying to overcome very specific barriers or just figure out what is that first step towards getting a jail program or getting a PROACT program up and running, can call into this meeting. They can talk with the coordinators, and we can also have stakeholders, peers of theirs on the call that can connect with them there or offline. So our hope is to take some of this really awesome work that some counties were doing and continue to build capacity to the point where we're hoping every jail facility has a model like this. Right now, though, the CBHJ, outside of the 6 facilities or 5 facilities that we've been working with, works in 21 jails in total. So we're looking to have conversations with folks in those facilities about how we can move forward the implementation of medications there as well.
Very good. Thank you. And then for either Megan or Adam, has COVID impacted on the harm reduction contacts or ability to reach out to individuals post-overdose response?
Yeah, so for us, not so much in terms of like being able to still provide full services to clients. We had to modify our approach to it. So like, for instance, when we're doing wellness checks, we're not necessarily going inside the residence like we would have been prior to COVID, but instead staying outside on the front porch, kind of keeping that distance with our mask on. Same thing with within our syringe access program. We're meeting people outside, having that conversation, and still being able to provide services. We've actually seen an increase in participants accessing services throughout COVID. But in terms of like, has there been a barrier to being able to provide services? Not from our end.
In general, we were a little bit more restricted with face-to-face contacts, and so we were limited to phone calls. We're getting into the groove here of getting into face-to-face. So as I mentioned, hopefully October 1 we'll start to do some face-to-face reach outs to resume those types of contacts.
And again, kind of follow up to that same question. Are you finding, is there any protocols that you have in place for voicemails? Again, thinking about that process, Adam was talking about that, people generally don't pick up numbers they don't recognize. Is there any policy or practices that you guys have or protocols for voicemails?
Yeah, so I mean, on our end, we keep it very discreet. I wouldn't say anything personal. I might just say this is Josh with the Red Project or something to that effect. Very discreet, no personal information or anything like that, or why I'm calling. Just Josh, Red Project, give me a call back. I'd appreciate it. Very simple.
I'd agree. Yeah, we do something similar. I mean, certain voicemails are not. They might just list the number, and they might not have. If somebody has a voicemail that's set up with their name, you can have a little bit more freedom to leave a little bit more detail. But otherwise, we're leaving our name, just asking for a phone call return. That's about it.
And Leonard, as far as the PROACT model with the positive legal opinion that you were able to secure, do you hope that the other 2 EMS agencies in Kent County might decide to join in the process of the work that you've done with PROACT?
Yeah, we hope so. So of course, all this EMS data is owned by the specific agency, so it'll ultimately be up to them on their willingness to really engage. So we've been in touch with Rockford Ambulance a little bit more. They've been on the calls, and I think from this legal opinion and sharing with them, they may be more receptive. AMR is a much larger organization, and really adding them on would be, over double what the Red Project plans to receive from Life EMS. So, throughout the process of getting Life EMS referrals and Red Project services in place, working out the logistics, making sure it's smooth, and then we're also a research entity, so we're really interested to see what the outcomes are looking like. So we're definitely plan to reach back out to these two EMS agencies, and I think we'd have a strong argument once we've got some systems in place and data backing it up, showing, hey, that we can really save lives here. So,
absolutely. Thank you. Brad, this question's for you. Can you talk a little bit more about the low threshold buprenorphine? Would that come through your primary care provider, or how would that process work, or how does that program look in other communities that you talked about it be coming out in?
Yeah, so I think in some of the communities it does work through a primary care provider. The one example that we had looked at in Ithaca, New York, came through there. Others of them are providers that are setting up in mobile units in communities, at the syringe exchange sites, as I talked about, part of a homeless outreach team, and the providers working specifically as part of that team. So, we're looking for more examples of these. So as folks are doing this type of work, we're hoping to find them in Michigan too that are doing some of this low threshold buprenorphine initiation. There's just one other thing I wanted to add to those previous questions about the PROACT and the difficulty of these phone calls, which I imagine a lot of folks are difficult to reach. But from the information I'm seeing, at least 25% of the people that are getting referred through this program are getting some sort of services afterwards. I mean, that is huge. That's big numbers to get people linked into any sort of services after a non-fatal overdose event. So, while the methods are probably frustrating, and you all are doing the hard work of this, it's paying off. The data, I think the preliminary results are already pretty remarkable.
Agreed. Question for Brandon. What is a key in your experience in working with sheriff's offices to have them consider implementing an in-jail MAT program?
A couple pieces that we found to be most effective. One, they don't want people back in their jail, right? They really like their job is to keep the community safe, but they want people to not be part of that recidivism door. And there's tremendous data now that shows that people who participate, the level of criminal behavior that people participate in significantly drops when they are on methadone. And so being able to show them like, hey, we've got a bunch of data here that shows like once people are stabilized, that is what's going to keep them from coming back. And a lot of the problems in jails, the donkey kicking on the doors constantly, the terrible behavior, that a lot of times has to do with SUD and mental health issues. And so when you get people properly treated, a lot of the problems within the jail go away. But the most effective one, or the most probably one that they care about the most, is the legal aspect. Outside of keeping the community safe, I've had multiple jail commanders tell me their number one job is to not get sued. And they have huge liability here. Like they know this isn't one case from some small circuit. This has been ruled on by a federal appeals court. This is the president now, and there's been several cases that have followed now. And so I approach this from it's the right thing to do. But then I also make sure I talk about during that conversation, hey, I'm looking out for you guys. Like you've got a lot. You're really open to liability on this, because they are. That's not a leveraging situation. They really truly are open to litigation. And look, nobody wants to be sued.
Great. Been a minute since I've heard the donkey kick line in a while, so brought back memories. So
Can I add one thing to that, Matt, about those
absolutely,
lawsuits?
please.
That we've heard as well. So like we scan for a lot of these lawsuits to see when they're occurring, where they're occurring. And what we've learned is that a lot of them aren't even public. So we've learned over the past, I believe it's 5 years, there's been about 8 million in lawsuits pertaining to a lack of services in jails. And they're not all on the news. Sometimes these cases get paid out. So even though you don't see these lawsuits occurring in the media, sometimes they're still happening in the background.
Yeah. And I may make this the last question here, but for Brad, for some rural communities, again, what is our process, or what do we suggest for if not all 3 forms of medication are available in those areas due to just geographic restrictions for the provider side?
Yeah, and this is, again, kind of hopeful thinking here, but it has to be that jails in these rural areas start to point this out. They have to become the ones with us, and we're happy to sort of elevate their voices where we can. But when there's not methadone available in a community, we need to identify that the jail wants to have methadone in that community, that they would be able to provide it to the folks in the communities, and then work with our partners at the state to see where we can get new OTP options available. The other thing to consider is subuclade. So we've talked a little bit about this internally in our team, an injectable buprenorphine that folks might have. But again, it's really where individuals are going to go afterwards to continue to receive treatment. The other thing I would say with rural communities, ideally it's best to have your provider be local, but with telemedicine being what it is, we're seeing folks using providers that are not in their own communities sometimes. So I think that there's expanded opportunities for stuff like that going on right now under the COVID regulations.
Okay. Again, I'm going to try one last question here, and to respect the people who asked them. Leonard, any connectivity that you're seeing with PROACT and the decrease in criminal justice contacts? Any correlation that we're hoping to see in that regard?
Hoping to see, certainly. I'll say that I think we're in a really good place on a data side. So note that these EMS referrals just started happening maybe about a month ago. So it's going to take us a few months, not only for to work out a little more system kinks, then also kind of see what happens to the folks who do engage in this kind of service, and what happens to the folks that don't. So criminal justice outcomes is definitely one of the areas we're looking at, and of course, further non-fatal or fatal overdoses as well, and then treatment engagement on a number of levels. So that's kind of our next phase, and looking forward to sharing that with you once we get it.
No, thank you. And I think that's really all the time we have for questions today. So I just want to thank, first and foremost, the Michigan Health Endowment Fund and Becky Sianki, the Director of Behavioral Health Services, for leading us off in this endeavor today. It's their support and vision and shared vision with the CBHJ that has really made this work possible, and we greatly appreciate that, and it's important for us to point that out. But I want to also thank everybody for joining us to learn about the great work and the people around the state that we're working with and the country and doing to expand our treatment ecosystems to save lives. We appreciate everyone's commitment to this work and are grateful as a center for your partnership. Just a reminder that you will be receiving an invitation to join us at our monthly OTE Community of Practice meetings, where we will hear updates from around the state on efforts to implement MOUD in this jail, naloxone distribution, and post-overdose response programming. These meetings will be held on the 3rd Friday of each month, beginning on October 16th. We'd also like to let you know that we have an OTE Community of Practice Lunch and Learn coming up on October 7th. The topic will be the opioid epidemic in rural communities. If you're on our mailing list already, you should have received the invitation about this event, but we will also send a reminder to register as the date gets closer. We look forward to seeing and joining you on October 7th. Lastly, as you exit the webinar today, a satisfaction survey will open on your web browser. We would appreciate you taking 2 minutes or less to complete the survey to provide us feedback on this event and to help us plan for future events. Again, thank you for your participation today, and have a great day. Thank you, everybody.